So the intervention that we're going to share with you today was originally developed prior to the COVID-19 pandemic. And then in the response to the pandemic, we digitalized the intervention to make it available to perinatal women with moderate to severe mental health problems remotely. Because similar, across the world, we were only able to see our most unwell patients, so women that were able to stay at home and didn't require hospitalization. We weren't able to run group programs during the first phase of the pandemic, and actually a bit later as well. So I'm going to tell you a bit about the intervention and when it was developed. So I'm going to talk about the feasibility and the effectiveness of ACT for perinatal mental health. We've completed a qualitative study where we interviewed the therapists who delivered and helped develop the intervention into a digital intervention. And then we've got a mixed methods evaluation of the safety, acceptability, and preliminary effectiveness. And we also have a range of other sort of studies going on at the moment. We're going to focus on the kind of the first phase of development in the UK, and then we'll talk about similar development in Malaysia. So before the pandemic, we ran the group. It was an 8-session group, 2-hour sessions, 2 hours every week. And obviously our health systems are quite different between Malaysia and Wales. But our women, the women that we work with, have moderate to severe mental health difficulties, often comorbid diagnoses of depression and anxiety, but also PTSD, OCD. Some people had a diagnosis of a personality disorder, if you believe they exist. So there were a range of presentations that women presented with, and they were able to access the group. What was really beneficial, I think, is because the group is transdiagnostic. So ACT, as we will probably know, or some of you may not know, ACT is transdiagnostic. So it's a really good intervention that we can have readily available, delivered in the service. Every 8 weeks, we'd start a new group, and we wouldn't have to wait for women with the same diagnosis to be eligible for the group. So it means that we can always have a psychological intervention available. The only exclusion criteria we've ever had really is currently floridly psychotic. So we've had women who have had a psychotic episode in the perinatal period but currently stable. So they might be experiencing positive symptoms, they might be experiencing negative symptoms, but they're manageable. So they're able to stay in a group. And women with a primary diagnosis of a substance abuse disorder were not eligible for the group. But other than that, there was no other exclusionary criteria. The group was delivered face-to-face in community venues, so in churches, halls, things like that. And the first evaluation, which was published before the pandemic, we found that the group was effective, could be delivered safely and feasibly in our setting, which is in a National Health Service, the NHS, secondary care mental health. So for your probably your 5 to 10% most severe women with the most severe mental health problems in the population, in the pregnant and postpartum population. So again, I should have said women could be pregnant or postnatal. So in response to the COVID-19 pandemic, which feels like a long time ago now, March 2020, we were supported to adapt the intervention by our health board, so the organisation. At the time, a lot of staff in services were being redeployed to kind of critical care, to health settings, but we had it agreed that our service was essential. So we were able to keep our staff. We were provided with some funding for new ways of working. We were allowed to use Zoom, which at the time was groundbreaking. We were never able to even email our patients due to the rules of the organisation. So to be able to use Zoom was, really quite amazing at the time. We were probably the only health board in Wales that were able to do that, and it meant that and in the UK, across the UK, a lot of services were very slow to pick up this way of working. So we were one of the first services in the UK to be delivering group programs really quickly. And we were lucky that one of our patients that we were working with worked for an insurance company, and they did a really good experience with us, and they wanted to give back, so they bought us loads of tablets with data, because we were really concerned about accessibility, to make sure that people from a more poor background weren't discriminated against in being able to attend. So if there was a problem, we were able to sort of, you know, drive to their house and give them a device that they were able to use to sort of, you know, join online. So that's what's happened there. So I'm just going to move that. So the aim of the intervention was to increase psychological flexibility and resilience, to improve mood and anxiety symptoms, to improve mothers' self-confidence and self-efficacy in their parenting role. And as I said, and as all of you who know about acceptance and commitment therapy, it's a trans-diagnostic intervention. And as I said, the only exclusionary criteria were substance abuse disorders or currently very acutely unwell. And those women would have been in hospital anyway. With me. So the first group, we stayed with the 8-week format during the pilot phase of the intervention. And we were quite dubious really about working online. I didn't really think that it would necessarily work. We were quite worried about safety. We were worried if women became suicidal, how would we manage that risk? We were worried about, you know, I think group programs can be really good for a number of reasons. There's the specific factors unique to the therapy, but also the non-specific factors related to being in a group. And the benefits women get from coming together, reducing stigma, sharing their experiences. So we thought maybe that stuff would be really difficult to replicate online. So it felt like a bit of a jump into the dark, but we stayed with the original manual for the first phase. We did reduce the sessions to 90 minutes from 2 hours, because I think 90 minutes is more than enough to spend at one time on Zoom. The intervention includes classic ACT method and techniques, supported by exercises developed specifically for the perinatal period. There's a standard format to each session. So there's mindfulness practice, first of all, or cognitive fusion exercise, followed by homework. Feedback, so each week women are set homework, and then they feed back to the group about how it's gone, and the group will problem solve with each other and maybe think about ways that they could adapt if things aren't going well, or celebrate the successes of when it is going well. And then there'd be a teaching and a practice of specific ACT skills and concepts that map onto the Hexaflex on the right-hand side of my screen, which might be a left-hand side. I'm never quite good at left and right. What was more unique with the intervention was we developed a compassion-focused module as well that was always part of the original 8-week program, because we know that self-compassion deficits are a problem for perinatal women, who often neglect their own needs for their babies. Particularly then, that's even worse if women have a mental health difficulty. So self-compassion is a theme that runs throughout the intervention, but we also had a specific module on that originally. We first developed the intervention back in 2014. So it was being run for about 6 years routinely within our service prior to this adaptation. And within our health system, our kind of context, we're a multidisciplinary team where we have psychology, psychiatry, community psychiatric nurses, occupational therapists, nursery nurses, an obstetrician. I think that's pretty much mostly the team, and a midwife. And the group was run by our community psychiatric nurses, our trainee and our assistant psychologists, and supervised by myself, or some of our senior ACT therapists within the team. So it's a quick overview of the intervention. We do an introduction to the group and the ACT model, kind of doing the contract, exploring hopes and fears. Then we move to mindfulness and acceptance. Then we focus on mindfulness and thought diffusion, then to understanding and regulating emotions, then to self-soothe and self-compassion. Session 6 is valued living and committed action. Session 7 is committed action, willingness and goal setting. And values, I should say, those two sessions focus on overarchingly. And then we review, you know, on the last session, we review the learning, we think about what we want to hold on to, people develop a bit of a bespoke plan really for action for going forward. So that was the 8-week program. The adaptations for online, like I mentioned, included 90-minute duration instead of 2 hours, exercises adapted to suit virtual delivery, use of the chat function and breakout rooms to promote connection between the participants. We were really keen to try to encourage interaction and sharing amongst the women who come to the group. We used more videos and to break up the sessions because, you know, 90 minutes is quite a long time, particularly if you've got a mental health difficulties. We know depression affects cognitive functioning. We know anxiety can impact on engagement. So we were really mindful of the different symptoms that women presented with and how that may impact on their engagement. So 90 minutes is pretty much, I think, the longest you should have a group, really. Group contracts were completed before attendance. So we did some stuff prior to group. So we talked about safety. We talked for women with a history of deliberate self-harm and suicidal behaviours. We had a safety plan put in place. We would talk to their care coordinator. So if you're in secondary mental health, everybody has a care coordinator or a key worker who is responsible for their care. So we would keep a close liaison with those people outside of group for those that we are more worried about. And the measures were digitalised and completed electronically via online links. I'll share this maybe at the end. So we, as part of the adaptation, so I'll have to come out to my presentation and go back in, we made animations to help convey key skills. And as part of the cultural adaptation, we've been making animations with our Malaysian colleagues as well, because as we learned, you know, some of the concepts and skills need really thinking when you translate them into the Malay language, and also the cultural context of Malaysia is different. So in some of our skills and techniques, we talk about having a midwife and a health visitor and what hospital appointments look like, and our healthcare systems are so different that some of the metaphors don't work for the Malaysian, Southeast Asian sort of context. So we're working on that at the moment, which is really exciting. Mindfulness exercises, as you probably know, are kind of frequently practiced in ACT interventions. These exercises are aimed to help mums regulate their emotions and levels of arousal at the start of each group session, to provide skills that women can be in the present more so than in the past, or kind of often with perinatal women, they're planning into the future. What have I got to do next? What are my list of chores for the day? And it's quite hard to be in the moment, to really appreciate the present moment. So trying to increase those skills and to help mothers pay deliberate attention to moment by moment experiencing, and to practice self-compassion and letting go of judgment. So we know that the perinatal period can be a time of, you know, it's often, or traditionally, when I started my career, it was still around then that, you know, pregnancy is a wonderful time and women flourish and they thrive and their hair gets thicker and their skin is glowing and it's beautiful. And actually it can be really, really hard, as those of you who've had a baby know, or those of you who are fathers who've, you know, have partners who've had babies. You know, it's an amazing thing to grow a baby. Wow, do you know what I mean? Like, what a massive thing to happen to your body, and all those changes can have an impact physically and psychologically. And if you have a prior history of mental health problems, or no history, but kind of have an onset of a mood or anxiety disorder during the perinatal period, that challenging time can be even more challenging. And we also find for women with a trauma history that pregnancy and parenthood can often reactivate trauma memories and past difficulties that they've tried to avoid and push away. Because I think as any of us become parents, we go through a process of adapting to that change psychologically and physically. And we might think about the things that happened to us in our childhood that we want to keep, that we want to hold on to, the things we want to pass on to our children, but we'll also be thinking about the things that we want to leave behind, and maybe the things that our caregivers did that we don't want to repeat. So that's quite a normative process. that can be disrupted by mental health difficulties during the perinatal period. So it's really important to think about judgments, rumination, and the content of mental activity, and how maybe sometimes women can get hooked on particular ruminations, judgments, and negative thinking styles about themselves. So the skills are really trying to create flexibility around that kind of thinking. So we were keen to do a qualitative implementation study of the therapist initially. So we ran 6 groups over the first year of the pandemic. So every 8 weeks we ran a group, and all remote. And we really wanted to pause and think about what we'd learned. So we did in-depth interviews with all of the therapists who'd who'd run the intervention. And immediately after each session, during the first 4 groups, we would meet. We would always meet for a debrief as facilitators after the group to think about, is there anyone we're quite concerned about that we need to liaise with the key worker? We need to pass on information. Anyone we need to follow up if someone became distressed. But then also we had about half an hour where we would reflect. So the 2 therapists would come together and reflect on the experience. What were we doing? What do we think is working? What adaptations do we made? What maybe didn't work? What could we do differently next time? And we recorded those reflections. So the kind of data that we had for this study was sort of 4 groups, 8 sessions per group of reflections with the facilitators, and then also semi-structured interviews with the facilitators, which I think was 7 who had done it up to that point. And that included psychologists, nurses, and an assistant psychologist and trainee psychologists. Okay. So the first theme that came up was barriers to accessing psychological therapies in the perinatal period. So the idea that there are organizational barriers impacting capacity and delivery, for example, staffing, geographical spread. And these are some of the quotes then. So a major barrier in Wales, I think, is staffing. So we don't have enough clinical psychologists in the specialist teams or enough psychological therapists in primary care. So one of the, and Wales is it's quite a geographically sparse area in some. So there's concentrated city, urban areas, and then mountainous and coastal regions. And the patch that we covers the capital city, but goes down for about 20 to 30 miles down the coast. So there's some quite rural areas that can take about 90 minutes to drive to sometimes. And for those women we found who live in the more rural part of the patch, they often wouldn't come to our in-person groups because it was too difficult to get there. There wasn't great travel. It would take a long time. So actually, one of the themes coming out was maybe this intervention is going to help engagement for people who live further away. And then there's service user barriers to engagement in the intervention, including shame and stigma, working commitments, and childcare commitments. And I think in the work that we've got coming out of Malaysia, we've saw similar kind of barriers. And there's barriers of childcare. We've mentioned that one, and of course we all know about the impacts of stigma in the perinatal period. And because it's seen that it's meant to be a time of complete happiness, women can often feel ashamed and also incredibly disappointed that something they'd looked forward to, maybe from when they were a little girl, of having their first baby, is not this fantasy. It doesn't live up to what they expected. So those feelings are really difficult to even acknowledge, I think, and to talk about. And that can be a barrier to accessing healthcare, particularly mental health care, I think, in the perinatal period. The impact of COVID-19 in the acceleration of online group therapy. So facilitators reflected on the impact of the pandemic and the impact on women being isolated and alone. So we had, it's crazy when you think back to what life was like then, isn't it? And we had women who'd never met another woman for a year. They'd been in their home alone for that whole time. We had babies who'd never met anyone other than their parents. Normally, babies will be going to baby groups, they'll be going to childcare, they'll be staying with family members. So all of those normative developmental experiences were not there. So we were, thinking about how we could maybe connect people. And one of the things that we did as well at that time is, as things started to open up, there was one, I think it was maybe 6 months in, we were allowed to go for a walk with other people, but we weren't allowed to sit on a bench or stop. And you think, oh my God, can you imagine that now? And when we were allowed, we started maybe to say, like, well, let's go, we'll do a walking group, or our nurses would try to get the women together outside with their buggies, with the babies, just to try to sort of increase connection. Not that wasn't a core part of the intervention, but something we did probably, after this pilot phase when we were allowed. Yeah, and then the quotes you can sort of see there. And you can see the last one. So we've just gone through a lockdown period again, haven't we? And actually we've maintained our attention so much more than one of the summer groups. So this is talking about, we had the first lockdown, then we had the summer where things opened up, and then we went into another lockdown. And what we did see is our two groups that were run over the summer, there was less engagement, but that was because it was the first time people were allowed to go outside, to see family, to go on holiday. So I think that was partly due to the context. But yeah, that context did impact doing the development phase. This theme came out that COVID-proof therapies provide continuity of service for service. So facilitators reflected on the major efforts they'd made for a continuity of service, including the provision of online ACT group therapy. Kathy remarked, in one positive, COVID is terrible, but look how much we've done. So we were all really surprised as therapists that what we'd achieved, because I don't think any of us thought that this was going to work so well when we started. It was initially out of desperation, but it's now routinely delivered in the service remotely. We don't run in-person groups still at the moment. We hope to source community venues to do a couple of groups a year, but for a lot of women, this works and it's good enough. Facilitators felt that diversifying access and treatment options and choice was really important, and that was a real benefit of the online group. And I, just for the sake of time, I won't read through all of the quotes. And these are some of the benefits then that came out of online group therapy, as well as the challenges. So we were worried about the lack of evidence base, so we worked to develop that. The normalization of mental health difficulties and suffering and struggling during the perinatal period came out. Online could be less exposing, so for some women it's easier to engage than it is when you're in person. Social support, we were able to kind of cultivate a supportive climate and environment where women did feel supported by other women. Empowerment, flexibility and accessibility. And then we move to the challenges, which include technology and internet connection. So obviously sometimes our internet connection just disappears, which is a challenge. Some people, even though we were able to offer a tablet to engage, sometimes that didn't work for everyone. We found there's less chance to reflect online. Limited non-verbal cues. You need to be more directive, you need to ask more questions, you need to build in more exercises. There's less of that sort of emergent themes that come out because there's maybe less conversation, so you do have to encourage people to talk more, I find, when we deliver things online. But that makes sense, doesn't it? I think we've done that one, haven't we? And these are further recommendations then for best practice. I've gone forward. So that's, like I was saying, more directive communication, more interactive elements for sharing, session length and group size, kind of developing guidance, developing contracts before, always co-facilitate. So if one of the facilitators internet connection goes down, there's somebody else who can carry on. And when one person's leading the delivery of the content, the other person's monitoring the room to see how people are responding, to try to get an idea of, is anybody distressed? Are they kind of connecting with the material? Monitor the chat function, and to be responsive to that way. So you always need at least 2 facilitators online. And just being really creative and thinking how we engage people. So I won't have time to read through all the themes, but they're the main things. So this study now is, we're about to submit this finally. We've been so busy with our clinical jobs and trying to develop our services, we don't get time to do research, unfortunately, not as much as we'd like to, but this study's all written up and ready to go. It's a replication of the pre-COVID paper, but obviously with the online intervention, and we're also now looking at the outcomes of the in-person versus online to see if there's a difference as well. So we were looking at sort of feasibility, safety, and effectiveness. So how many sessions women attended, reasons for not attended, reasons for dropping out, referrals to other services. So if women kind of got worse, did they need to go to crisis or inpatient services? Because that would be an indicator that maybe the intervention might be having harm. So we were interested in that outcome. We used the EPDS, the GAD-7, the CORE-M, and the old school ACT process measure, the acceptance and action questionnaire. We now use the compact, but this is a rep. We were trying to compare both groups, so we were using the older measure at that time. And then post-intervention mothers completed an end of therapy questionnaire that included open and closed questions about their experiences, looking really at like helpfulness. And then we used thematic analysis to analyze the data. As you can see, women ranged in age from 21 to 40 years. 62% were pregnant at the start of the intervention. The majority were in a relationship. And so with all the Zoom things, I can't see my graph. And about 60% of our sample prior to the current episode had contact with mental health services. So 40% were generally new to mental health services, and then the rest, 60%, were kind of patients who were already known. Okay. So this is the range of diagnoses. So as you can see, there was a complete range of presenting problems that women came with. Often there was comorbid difficulties, which I think is quite not uncommon in the perinatal period. Women often present with problems that kind of cross the diagnostic categories, depression and anxiety primarily. But you do get women who have a pure depressive disorder, but I think comorbidity is more the norm than the exception in the perinatal period. And then the majority were also stabilized on medication. So women needed to be on the medication at a stable dose for a couple of months before they engaged. And again, it wasn't, no surprises. The majority were on antidepressants, but there were women on mood stabilizers and antipsychotics, which reflects the bipolar or population really. So let me move that. So 28 of 40 women, 68% were defined as treatment completers, having attended 4 or more sessions and engaged at each stage of the intervention, so at the beginning, the middle, and the end. Reasons for dropping out. So of the 13 women who dropped out, 3 reported finding the online group environment overwhelming. 2 delivered their babies before the end of ACT. 3 couldn't attend because of appointment clashes, so maternity appointments or work. 1 moved out of the area, and 3 were physically unwell, for example, with HG, hyperemesis prima gravida. So, we weren't being told that they were dropping out because they didn't like the intervention. There was for other reasons. There was 1 woman who didn't like having a camera on, and said that she didn't want to engage for that reason. But generally, it was for, understandable reasons. None of the women got worse or were referred to the crisis home treatment team or inpatient services during the intervention. So that tells us or gives us an indication that it's certainly not making things worse. And, it is also improving symptoms, which is good, which is what we'd want. The average number of sessions attending was 6.4 with a median of 7. So when women engaged, they tended to come all the time. And if they did miss a session, again, that was for understandable reasons. So physical illness, clashes with other appointments, maternity problems with employment or childcare. And some women just forgot occasionally. They might forget what day it is, because when they were at home in the pandemic, every day looked the same. And sometimes people just got a bit disorientated and forgot if it was Monday and it should have been Tuesday or something like that. So that did happen sometimes. All of women reported the intervention helpful and the facilitators helpful, and the majority rated it as very helpful. And then we can see significant improvements in, so the core, for those of you who may not know, it's a measure of psychological distress, and it's a transdiagnostic measure, which is why we used it as the primary outcome in our studies. And it's also the primary measure that most mental health services use. So that's why we use it, because we could benchmark against all of the other services and data. So we see improvements in psychological distress, decreases in anxiety, decreases in depression, and improved psychological flexibility. So the findings really replicated the in-person delivery, which we were really pleased to see. So these are some of the themes that came out of the qualitative information. Oops, I'll go backwards. So the benefits of being in a group, these are quotes from the mums themselves. So I found, the group immensely helpful, and feel my mental health would be so much worse if I hadn't been attending these sessions. We had loads and loads of quotes, but obviously we've had to just condense it all down and select the quotes that really summarize each theme and sub-theme. Benefits of online, so easier to attend online, feel comfortable at home, fits around work commitments, good for childcare. So we do pre-sessions, and the care coordinator, we've got kind of a list of things to go through with women. So this is what you need to think about when you're joining online, create this environment, maybe have some snacks and a drink next to you, arrange childcare if you can. If you can't, have things to occupy your child. If you've got older children, it's okay to breastfeed, put in the chat and turn the camera off, let the group know. So we put a lot of thinking into how to attend and what can enable attendance before women attend. And that we got better at that as we went on, and some of that then was reflected in the themes. Negative difficulties of online, so reduced concentration, missing the social aspect, technical difficulties, difficulty to see self and contribute, perceptions on the time of day. So some people thought it was helpful. We usually did it around midday, around lunchtime. Some people thought, it wasn't helpful, but overall it seemed to be a good time to run the group. Impacts of COVID, feelings around session time, act-specific skills, and then suggestions for improvement. And then often I think the suggestions were around having more time to connect and to share experiences with others in the group. So that was phase one. That kind of was the first year of the pandemic. And then we went through a period of learning. These are some of the quotes. Again, so I'll leave them there. I won't focus too much. I want to make sure I give Farah enough time to share the great work that we're doing together. But they're the themes. So then we kind of did an adaptation following the pilot phase. We had a group of women who'd accessed the intervention with lived experience of perinatal mental health problems. We looked at the data we've got here, the data we've got from the therapists. And then we made the following adaptation. So we made it into a 10-week intervention rather than 8, because it felt like particular sessions weren't given enough time. And that was the theme that came out of the research. Creation of animations of co-act skills, increased time spent on emotion and compassion-focused sessions. We developed a therapist training package, and we developed a trainer package. And that's where Farah comes in and will share with us the cultural adaptation part, which is the really exciting bit of the work that we've been doing together. So I'll hand over to Farah to share the slides that she's put together. Am I taking up the screen? Oh, I need to stop sharing, don't I? There we are.
Let me just pull up my screen.
I was trying to think when we started, Farah, was it September 21 or 22? It was 21, wasn't it?
Yeah.
Yeah.
It was early on.
Yeah,
I
so
don't
we
think that we've kept at it for that long. All right, so can you guys see the shared screen? Or perhaps I'm sharing the wrong screen.
there we are.
All right. Can you guys see my screen? So first of all, Assalamualaikum. Good morning, evening, or afternoon, wherever you are. Thank you so much for those of you who are hanging on in this 24-hour conference. I don't know if anyone is here most of the time, but thank you for, spending some of your time to listen about the talk or the research that I've done with Cardiff and the collaboration that we have made together. So what we have done is basically adapting the intervention that Cardiff developed, which is called Act for Perinatal Mental Health, or we call it PNMH for short. So today I will talk to you about the Malaysian perspective and what we have done from our side and how we have tried to culturally adapt this model so that it's more appropriate to our Malaysian population. All right, so for a brief overview, the Cardiff University developed the Act for Perinatal Mental Health as a remote group-delivered ACT intervention, right, for perinatal women with mood or anxiety disorders who are actually accessing their center in the Perinatal Community Mental Health Service. So through extensive collaborative effort, as Cerith mentioned before, which we started in around 2021, September 2021, we actually got in contact with each other. We realized how wonderful this intervention was, how there was actually a service gap in Malaysia, how we as experts or mental health practitioners in Malaysia feel that this is a gap that we want to fill. And we feel that the intervention that was developed by Cardiff is something that, number one, is feasible for mental health practitioners to learn, to disseminate, and even perhaps to translate so that it's more easily applicable to our population, right? So through extensive collaborative effort, the experts here, we sought to collaborate and culturally adapt this intervention among our population. All right. So first of all, before I forget, my name is actually, I forgot to introduce myself. My name is Dr. Nurfarahin Musa. So I'm actually a psychiatric medical officer based in the land of Sabah in Borneo, Malaysia. Right, so I have been interested in ACT since I was introduced to it by my mentor, Dr. Nicholas Pang, who sadly was unable to attend today, but I will try to the best of my ability to present our findings and our research for his behalf. So he's the psychiatrist and an avid ACBS member, an avid ACT practitioner, and I hope that I would do him justice today by presenting the research that we've come up with so far. Right. So the study objectives that we aim to get with this intervention is to culturally adapt and modify the acceptance and commitment therapy for perinatal mental health in the context of the Malay-speaking population. So we want to try and adapt it to Malay, translate it from English to Malay, make sure that the context is also appropriate. And besides that, because if you noticed in Carrie's earlier presentation, there were actually evaluations pre and post intervention, and using those evaluations, he was able to determine whether the intervention was actually feasible, whether it was effective. So somewhat a tandem study that we do during this huge research is to validate the appropriate psychometrics to the Malay language to adequately evaluate the efficacy of the intervention and the effect. Right. So besides that, after we have done all that, we also plan to evaluate the safety, acceptability, and the preliminary effectiveness of the culturally adaptation of ACT PNMH, which would be in the Malay language. And we also plan to determine the feasibility and the effectiveness of ACT PNMH in the context of community mental health services in Malaysia. Okay. So our adaptation process was actually based on the cultural adaptation model as as presented before by Rogers in 1995. So in this adaptation process, we actually had 3 phases. Phase 1 was the establishment of contact between the University of Cardiff, Wales, and also Hospital University Malaysia, Sabah, which is where I am based at. Phase 2 is about the adaptation of the intervention to the local Malaysian context, to the Malay language. And it also included, I think as Cardiff mentioned before, preparing the appropriate images, animations, graphics, which were actually culturally appropriate to the Malaysian setting. And in phase 2, we also started to prepare and validate appropriate evaluation measures that we plan to give to the mothers prior and also after the intervention itself. Besides that, Besides that, we also plan to, in phase 3, we also integrated some of the observations and feedbacks that we have collected and coalesced in phase 2. And from this feedback, we plan to create a new version of the original intervention. And subsequently, with this new version, the finalized version, we plan to field test the adapted program in phase 3. So currently, in phase 1 composed of establishment of working group of researchers come practitioners. So the intervention development specialist role was fulfilled by University of Cardiff, mostly led by Cerith Waters, Dr. Jenny Barrett, and actually we were also helped by, I think, Miss Jessica Simmons and Mrs. Claire Taylor. So they had a really big role in helping us with supervision, in providing the materials, right, in basically guiding us throughout the whole way of the adaptation process. Then the cultural adaptation specialist role was fulfilled by the psychiatric team here in Hospital University Malaysia, Sabah. So mostly it was spearheaded by Dr. Nicholas Pang, my mentor, and also by me, Dr. Nurfarahin Musa. And the community, we also plan to get the collaboration of the community, which included various community leaders who were involved in the development of the intervention. So what I mean by this is, because we plan to adapt the intervention, a lot of the time we had to ask people in the community itself whether the intervention, when we actually translated it, was it actually understandable? Was it appropriate, right? And these people I will mention furthermore in my following slide. So in phase 2, we actually talked about the intervention itself. So if you notice, this slide is almost the same as Carith's slide earlier. So it's just to give you guys an overview of how the intervention looks like. So in Malaysia, we also did an online-based group therapy, and it was also aimed at increasing mindfulness and psychological flexibility. However, this time, the intervention that we adapted was spread over 10 weeks. So it was a 10-week program instead of an 8-week program. However, each session was still consisting of about 1 to 1.5 hours of content. And it was still presented in the same standard format. Usually we would start with a mindfulness exercise, and then we would teach some skills. Somewhere in the middle, we would actually ask for some homework feedback. There will be a review session. And sometimes in the review session, they could even call back the skills that they learned 2 or 3 weeks ago or 5 weeks ago, right? Or they can even bring any questions that they have regarding the intervention so far, right? But most of all, within this intervention, we actually taught the specific core concepts that are mapped into the hexaflex, as you can see. So the difference between the intervention that, the pilot intervention that Cardiff developed and the intervention that we actually culturally adapted is that, like I mentioned before, it was 10 weeks. So if you notice, session 3 and session 4 were both broken up into 2 separate sessions. So because the content was quite heavy, it was because a lot of the content actually to mothers in Malaysia, they were also quite new concepts, new terms, as a lot of Malaysian women were not actually exposed to psychotherapy previously or psychotherapy terms, psychological lingo. So I think it was very useful and actually an amazing thing that Cardiff actually broke down the sessions even more so that it would be easier for us as the mental health practitioners to deliver the intervention to the mothers. Right. So regarding the translation, so how do we actually translate the material? First of all, the adaptation group was formed, so led by Cardiff University and also by our team in University Malaysia Sabah. And then people from Cardiff, so the team from Cardiff actually provided us with the materials, which included the facilitators manual, which they just developed, the participants booklet, the worksheets, and of course the slides that we would use. It's actually a PowerPoint slide that we would use for the next following 10 weeks of the intervention. So this booklet, these worksheets, the slides were all translated by researchers in our team who are proficient in both the Malay and English language, and who also had knowledge regarding the context or the core concepts of ACT. So after this preliminary translation, members of the adaptation group, we revised this translation even more, and attention was given to the accuracy of language, its meaning, identifying local expressions, and also the terms for specific contents, right? Because people in the adaptation group, we know that they're already quite experienced ACT practitioners, so they would understand whether anything would be lost in translation. I think that's the perfect word for it. Whether any of the concepts, any of the contents, any of the skills that we plan to learn according to the hexaflex would be lost in translation. So that's why we had to revise the preliminary translation. And lastly, at the end of it, a panel of reviewers here in Malaysia was formed with 4 relevant stakeholders. So the 4 relevant stakeholders included mental health specialists with experience in perinatal mental health, primary healthcare professionals, and also new parents. All right, so the stakeholders represented academics and also practitioners, experts in the field, as well as potential facilitators and also potential participants of the intervention. So the members of this group of the 4 stakeholders revised the materials even more in terms of the relevance, and also commented on the intervention of the delivery. So whether it should be delivered as an individual intervention, as a group intervention, whether it was suitable in the primary healthcare setting or in a specialist setting, whether it was suitable in face-to-face setting or online setting. And most of the comments were very complimentary and consistent, but on few occasions that contradictory opinions were given. We actually discussed it among a group to reach a consensus so that there was a finalized, homogenized version of the translation and adaptation. So besides that, as Cerith mentioned before, Cardiff actually helped a lot in creating culturally appropriate graphics that we could include in the slides when we presented, when we taught this the intervention. So the initial graphics developed by Cardiff is this beautiful lady here. So you can see she's very beautiful. She has red hair. I think she's, in one photo, she's very heavily pregnant. In one photo, she's enjoying the view with her child, her just born child. So what Cardiff actually has done for us is they've come up with the idea that how about we make this more culturally appropriate so that when the mothers see the images, they would relate to it more. They can see themselves in that role, you know. They can see themselves around this rainbow of concepts. They can see themselves being mindfully aware of that surrounding. So that's what they have done. So as you can see here, I think a graphic designer from Cardiff, please chip in, Cerith, if I'm wrong. A graphic designer from Cardiff actually managed to make this very beautiful graphics. So each actually representing a major ethnic group in Malaysia. So from left to right, people from the Malay community, people from the Chinese community, and people from the Indian community in Malaysia. So it's very beautiful, and actually a lot of mothers, when they see these images, they see themselves. I think representation is very important, right? So when you see images that depict yourself in your best form, when you see images that are very psychologically flexible, when you see yourself as an important part of an important intervention, it puts you in their shoes. It makes you want to try harder to become this ideal version of yourself. It makes you feel that I'm included, I'm not forgotten, right? Psychotherapy is not just for people who have blue eyes and blonde hair. It's for people here too. So besides that, in phase 2, we also talk about what psychometric evaluations can we use to sort of determine the feasibility of the intervention. So the measures of depression anxiety that we have decided upon is the EPDS, the DAS-21, the GAD-7, and the Euroqual 5-dimension 5-level scale. So the reason why most of these interventions are actually almost similar to Cardiff, but I think Cardiff used CORE instead of EQ5D5L. So the reason why the Malaysian intervention used this scale instead is because a lot of measures of depression and anxiety, not a lot, but some of them are actually not validated into the Malay language. So as you know, the intervention itself is in Malay. It would be nonsensical if we put this, if we give them psychometrics in the English language. So of course we had to give them psychometrics in a language that they understood. So that is why we opted for the EQ5D5L. And besides that, we also wanted to find an appropriate measure for psychological flexibility. So as Cerith mentioned before, in their intervention, they actually used the AAQ7. However, as you can see in this next slide, AAQ7, we found that it was too brief as a measure of psychological flexibility. And the compact scale was more suitable as it was longer and had a better factor structure that covered more facets of the ACT skills. So as part of the measures, interestingly enough, in the middle of our main cultural adaptation study, we decided to make a mini study where we actually validated this compact scale into the Malay version, so that not just now, but even in the future, anyone else using ACT in Malaysia, if they wanted to determine psychological flexibility, there is a Malay version available for them. And thankfully, Cerith was able to get in contact with the person who made compact. I think Dr. Nima Moghadam, I'm so sorry if I butchered his name. So he has kindly given us the, what's the word? His blessings to his blessing, and he has agreed for us to validate his skill. Okay, I just realized that I have 5 minutes left, so I'll try to breeze through the final phase. So the final phase, modification of the content. So as I mentioned before, in the second phase, we actually translated it and we adapted it. But in the third phase, we wanted to modify the content even more, according to the ecological and validity model, as mentioned by Bernal and Adams in 2017. So in this phase, they recommend the guide to modifying the content is using 8 different domains, using our language, persons, metaphors, content, concepts, goals, context, and also method. Right, so a lot of the things we had to modify according to the culturally appropriate Malaysian population. So for example, regarding the language, we had to make it simplified. We had to reduce the complexity of the language, as we know that a lot of Malaysian population, especially in Sabah, in Borneo itself, are of the low literacy group, are of the low income group, right? Some of them are even haven't had any secondary education. Right, so that is why we had to simplify the language. And secondly, we had to find specific terms that were local, which were culturally appropriate locally, right? So for example, thought diffusion and unhooking from thoughts had no direct translation to the Malay language. So we had to try and find certain equivalent terms to replace them with. And certain terms like judgments or mindfulness had multiple possible Malay translations. So we had to pick just one translation and homogenize this one specific term to be used throughout the whole intervention. And besides that, we also, when modifying based on persons, we also had to think about building a warm, positive, and encouraging environment to promote group discussion, because we have to consider the higher levels of stigma towards mental health in the Southeast Asia population compared to the United Kingdom, where the intervention was first developed. Besides that, certain concepts also had to be appropriated for the Malaysian setting. So for example, concepts like my puppy had to be replaced to a more culturally appropriate animal. As most know, Malaysians' primary religion is Islam. So they have a restriction regarding the use of dogs as pets or guides. So perhaps my puppy was not the most appropriate term for us to use. And other than that, conditions like imagine that there's a visit from a health inspector and he's knocking on your door. How do you react? So things like this, we had to omit from the slides. So instead of saying it's a visit from a health inspector, it's a visit from your mother-in-law. So because in the Malaysian healthcare system, we do not actually include regular health inspector visits during the perinatal period. So this actually shows a difference in our healthcare services between these two countries. And besides that, analogies and metaphors and traditional sayings of the Malay language and the local context were even included to make them feel more inclusive. So for example, analogies like watching the observer self from the top of Mount Kinabalu, which is the highest mountain peak in Borneo. Proverbs like bagai menatang minyak yang penuh, which in Malay translate to giving your utmost care in raising a child. So things like this made the intervention more inclusive for the mothers. Besides that, we know that the original ACT PNMH mode of delivery was through virtual delivery, and this was carried over to the Malaysian setting. However, we noticed that these sessions were only applicable to mothers in the urban setting, as not every patient in Malaysia had access to widespread internet connectivity. So Borneo is somewhat like Wales, where we actually are disseminated. Like Sabah itself has a 3 million population. However, not a lot of them have access to mental health care services, tertiary services, internet services. So this acts as a limitation to the dissemination of the intervention, right? And lastly, the original ACT PNMH also invites mothers to bring their babies to the session. And this recommendation was maintained in the Malay intervention. Actually, most of the mothers really love that this was applied because they have never encountered intervention where they said that they couldn't bring their children, right? They never encountered an intervention which says, they never encountered an intervention which says it's okay to bring your child, it's okay if you're not alone. They never encountered an intervention which was very flexible and very understanding of how that this might be barriers to them receiving the intervention at all, right? So seeing that it's already 5 p.m., I'm so sorry for taking up too much time. I wonder if I can take up 5 more minutes. Maybe I'll ask our moderator, but if I can't, then I think that's it for my presentation today. Thank you so much, everyone, for tuning in and listening in.
Okay, I'm afraid that we will have to keep to time because I believe that the next few speakers are already in. Mandy, is that correct? You're the next chair, right? Yeah. So I think even questions we will have to probably reserve and direct it via email. Would that be all right to the two speakers? I myself have several questions actually. This is a very interesting topic, but I do think that we should keep to time for the sake of others as well. Yeah, so maybe if the two speakers wouldn't mind, and we'll contact you all via email. Would that be all right with the both of you? Okay, brilliant. So thank you very much once again to both of the speakers. I will stop the recording